Hello, and thank you for joining us for the presentation of our research project, Brain Volumes and Cognitive Motor Dual Task Interference Correlates Among Individuals with Cognitive Impairment, a retrospective analysis. My name is Caitlin Moreland, and along with my colleagues Morgan Wise, John Basterechea, and Daniel Christ, we will be explaining the details of our research study. Dementia is a highly prevalent problem that affects cognition and function in around 46.8 million people around the world. The care of those with dementia has an immense financial impact, costing around $1 trillion per year worldwide. This number is expected to double by 2030. The leading cause of dementia is Alzheimer's disease, accounting for 50 to 70% of all dementia cases. Other common dementias include vascular dementia and dementia with Lewy bodies. Alzheimer's disease is characterized by cortical atrophy with associated memory loss, slowness of performance, and difficulty performing previously familiar tasks. Other common causes of dementia have changes similar to those found in Alzheimer's disease. While some people with dementia are more commonly thought to have cognitive deficits, these individuals demonstrate motor deficits as well. Some examples of such motor deficits are decreased gait speed and quality of gait, and deficits with maintaining balance. These motor deficits have been associated with fall risk and survival in older adults. The effects of dementia are also seen at the intersection of motor and cognitive deficits as an impairment of the ability to dual task. Dual tasking is the ability to simultaneously perform motor and cognitive tasks without a decline of performance in either task. Dual task performance has been shown to be significantly decreased in those with Alzheimer's disease, and slow walking speed during dual task gait has been shown to be associated and predictive of both falls and the progression of dementia in people with mild cognitive impairment, a precursor to Alzheimer's disease and other dementias. There is much we do not know about the mechanisms underlying the dementias and how they relate to dual tasking and other functional deficits. Studies have shown that the cognitive and executive deficits in people with Alzheimer's disease and mild cognitive impairment are associated with atrophy in specific cognitive-related brain areas, such as the frontal lobes, hippocampus, and striatum. However, there is little known about motor-relevant brain areas and how they relate to motor and dual task function. Likewise, there is little known about the relationship between dual task function and cognitive relevant brain areas. Previous studies have identified brain areas uniquely correlated with dual task performance, including frontal, temporal, and cingulate regions. Although there is evidence that motor-related areas such as the basal ganglia and primary motor cortex can be affected in Alzheimer's disease and other causes of dementia, further research is needed to determine if and how the decreased motor and dual task function is related to brain volume changes or other factors. Now I will explain the aims of our study. Our first aim was to determine how brain volumes are associated with dual task performance in a mixed clinical sample of individuals with cognitive impairment. For our first aim, we hypothesized that motor-relevant brain volumes would be associated with motor performance during dual tasking, and that cognitive-relevant brain volumes would be associated with cognitive performance during dual tasking. The measurement of cognitive and motor performance will be outlined in our methods section later in the presentation. Our second aim was to determine how brain volumes are associated with dual task prioritization in individuals with cognitive impairment. For our second aim, we hypothesized that individuals who prioritize cognition and individuals who prioritize motor function during a dual task will have different associations with motor and cognitive relevant brain volumes. Our third aim was to determine how dual task performance is associated with gait and balance. For our third aim, we hypothesized that the combined dual task effect, which is a measure of the overall decrease in performance while dual tasking, would be more associated with gait and balance impairments than either motor or cognitive performance individually. The measurement of dual task performance, both combined and individual, will again be further explained in the methods. Next, my colleague Morgan will introduce and explain the methodology of our study.
Thank you, Caitlin. I'll now be discussing the methods. This study is a retrospective analysis using information gathered from physical therapy documentation and brain volumetric data through electronic medical records at Cleveland Clinic Le Rouvreau Center for Brain Health. Items that were extracted from the patient's medical records include demographic information, diagnoses, cognitive outcome measures, gait and balance outcome measures, and brain volumetric data from MRI. A thorough medical record examination was performed on a total of 603 patients who were evaluated for physical therapy between January 2017 to December 2018. Of those patients, only 248 had evidence of cognitive impairment based on a clinical diagnosis completed by a neurologist. Patients were excluded from the study if there was no data regarding dual task performance or no MRI imaging from within 6 months of the dual task assessment. Due to the uncertain nature of clinical diagnoses and high prevalence of mixed pathologies, individual clinical diagnosis was not included. The final patient sample included a mixed clinical sample of community-dwelling older adults with cognitive impairment. One of the significant variables in our study is dual task effect. This was obtained from performance on Timed Up and Go and Timed Up and Go Cognitive. Individuals completed the motor-only task first, the Timed Up and Go. They were instructed to rise from a chair, walk 3 meters as quickly and safely as possible across a line marked on the floor, turn around, return to their chair, and sit down. Prior to performing the Timed Up and Go Cognitive, individuals performed the cognitive task of serial subtractions by 3 from a number between 80 and 100 in a seated position in order to measure their single task cognitive performance. The number of correct responses in 20 seconds was recorded. The Timed Up and Go Cognitive was performed next, which is both motor and cognitive tasks simultaneously. Performance data from these tests were used to calculate key variables as seen on the next slide. I am now going to discuss important terminology to help further clarify important variables in this study. These concepts can be visualized by this figure representing an individual's performance on the Timed Up and Go cognitive test demonstrated by the black lines, compared to the Timed Up and Go and backwards counting tasks alone, which are demonstrated by the red lines. The horizontal axis represents motor performance, measured in seconds taken to rise from a chair, walk 3 meters, and return to the starting position. And the vertical axis represents cognitive performance, measured in seconds per correct response in the backwards counting task. Motor dual task effect, also known as motor DTE, is the relative increase in time it takes to walk 3 meters and back in dual task conditions. This can be visualized on the figure by the increased distance along the x-axis between the single and dual task lines. Cognitive dual task effect, also known as cognitive DTE, is the relative increase in time taken to give correct responses on the backwards counting task in dual task conditions. This can be visualized as the increased distance along the vertical axis between the single and dual task lines. Combined dual task effect, also known as combined DTE, is a measure that combines motor and cognitive effects and is designed to represent overall loss of function while dual tasking. Combined performance can be visualized in the figure as the area enclosed by the lines. The combined DTE is the relative difference between the two, visualized here by the shaded gray area. Lastly, task prioritization is based on the patient's choice to focus more attention on one of the two competing and concurrent tasks, either motor or cognitive. Patients were scanned using the same magnetic resonant imaging scanner, and brain volumes were calculated from an automated program, NeuroQuant, which processes MRIs for quantification of regional brain volumes. Based on the literature, some key areas we consider to be motor relevant include the superior frontal lobe, caudate, putamen, middle parietal, and cerebellum. Those considered to be cognitive relevant include the inferior frontal, hippocampus, and cingulate regions. Additional areas we expected to be associated with task prioritization and combined dual task effect are listed here. Several different outcome measures were used to examine an individual's motor function. The outcome measure used to assess gait was 10-meter walk test, both preferred and fast gait speed. Sensory orientation and postural control were assessed using Mini Balance Evaluation Systems test. And fear of falling, avoidance behavior questionnaire scores were used to assess avoidance behavior. 6-minute walk test and 5-time sit to stand were used to represent walking endurance and lower extremity functional strength. The data collected from electronic medical records were analyzed using Pearson correlation coefficients. Pearson correlation allows for comparison between variables to demonstrate a relationship. A positive correlation is demonstrated as one variable increases, the other variable also increases. A negative correlation is seen when the variables being compared demonstrate an opposite relationship. Therefore, as one variable increases, the other variable decreases. No correlation can also be seen when there's no significant relationship that exists between two variables. More specifically, for AIM-1, a Pearson correlation was used to compare brain volumetric data to motor dual task effect and cognitive dual task effect. For AIM-2, a Pearson correlation was used to determine associations between brain volumes and task prioritization. For AIM-3, the strength of relationship between dual task effect and gait and balance were compared. John will now discuss our results.
Thank you, Morgan. Now I'm going to discuss the results as they pertain to each of the aims mentioned earlier. And just to reiterate, for AIM-1, we looked to see if brain volumes were associated with dual task performance in our mixed clinical sample. We found that greater motor dual task effect was associated with slightly larger motor relevant brain volumes, meaning that worse motor performance during dual task was correlated with larger motor relevant brain volumes. We also found that greater cognitive dual task effect, meaning worse cognitive performance during dual task, was associated with a decrease in motor relevant brain volumes, and this trend was similar for combined dual task effect, which also increased with declining motor relevant brain volumes. We determined that motor dual task effect was not consistently correlated with cognitive relevant brain volumes. However, we found that greater cognitive dual task effect was associated with a decrease in cognitive relevant brain volumes. Once again, this trend was similar for combined dual task effect, which increased with declining cognitive relevant brain volumes. Next, for AIM-2, we looked at how task prioritization pertained to dual task effect and brain volumes. We found that smaller motor and cognitive relevant brain volumes were associated with increased motor prioritization during dual task performance, where motor dual task effect decreases less than cognitive dual task effect. Lastly, with regards to AIM-3 and how dual task effect correlated with measures of gait and balance, represented here as physical performance, we determined that decreased physical performance was associated with greater motor task prioritization, and that cognitive dual task effect is more strongly associated with performance on measures of gait and balance compared to motor dual task effect. Next, Daniel will lead the discussion for our study.
So what does this all mean? First, let's discuss our findings on brain volumes and dual task performance, beginning with the motor relevant brain areas. Our first finding was that larger motor brain volumes were generally correlated with increased motor dual task effect. Remember, the dual task effect is the decrease in performance while dual tasking. So what this means is that individuals with larger motor brain volumes walked more slowly during the timed up and go cognitive test. This is counterintuitive, as we would expect decreased brain volumes to be associated with worse performance. Other research is unclear on this topic. Some studies have supported our findings, demonstrating increased cerebellar volume to be associated with decreased gait speed, but others have found opposite correlations for regions such as the motor cortex. These findings are difficult to explain, but we speculate that if motor brain structures are relatively preserved, it may affect the way that brain resources are allocated to the competing cognitive and motor demands of a dual task. Next is our finding that decreased motor brain volumes were correlated with increased cognitive dual task effect, which again means worse cognitive performance on the timed up and go cognitive. This makes more sense. Although we are looking at motor brain regions here, many areas considered to be motor relevant have cognitive functions as well and could be reasonably expected to affect the cognitive component of a dual task. Additionally, other researchers have suggested that with degeneration of the automatic motor control networks in those with dementia, we may see more executive and attentional resources being used to compensate, thus leading to the observed increase in cognitive dual task cost. When we look at the combined dual task effect, which is a measure designed to account for both motor and cognitive effects and be a representation of the overall loss of function while dual tasking, we see very similar correlations to the cognitive dual task effect alone. This indicates that the cognitive cost of dual tasking is the most prominent feature of altered dual task performance in relation to decreased motor brain volumes. Some of the most notable motor brain regions identified in our study are listed here. The cerebellum performs balance and coordination functions, and other research suggests it may have a complicated role in dual task function. The paracentral lobules are thought to play a role in sensory integration and body awareness, and the parietal lobes, which are involved in visuospatial orientation, have been shown in other research to be associated with functional standing balance in this population. The knowledge that these brain areas are driving loss of function could be used to guide clinical interventions to target the most relevant impairments in those with dementia, especially if further research is able to clarify the roles of these brain areas and their functions. When we look at the cognitive relevant brain volumes, we see no consistent correlation with motor dual task effect. This is not too surprising, as we would expect cognitive areas to be more associated with cognitive function than motor. We did find that as cognitive brain volumes decrease, we saw an increase in cognitive dual task effect. This makes sense and is supported by other research suggesting that cognitive deficits in this population can be linked to atrophy of specific cognitive brain areas. The areas implicated in our study were consistent with the prior literature, including those associated with memory and emotion, such as the hippocampus and amygdala. Just as for the motor regions, we found that combined dual task effect was associated with cognitive brain regions in a very similar pattern to cognitive dual task effect alone, suggesting that the cognitive cost is the primary driver of loss function while dual tasking. For our second aim, we looked at brain volumes and dual task prioritization. We found that as brain volumes decreased, dual tasking became more motor prioritized. This could be the result of an intentional focus on gait for safety despite the neutral instructions, or an unconscious default strategy to prioritize gait. Other researchers have supported the idea of a posture-first strategy of gait prioritization during dual tasking to avoid falling. However, research findings are varied, and the literature suggests that dual task prioritization may be dependent on the difficulty of the component tasks, as well as individual characteristics such as the ability to perceive postural hazards. These variations do suggest that we can use dual task training clinically and alter aspects of the task and environment to elicit the desired strategy for a particular individual. For our third aim, we looked at how dual task performance correlated with performance on various measures of gait and balance. We found little to no correlation between motor dual task effect and gait and balance performance. This is notable because motor dual task effect is by far the most commonly used dual task outcome measure, both clinically and in research. Our findings suggest that cognitive dual task effect tells more about overall function in those with dementia. Once again, the pattern of association for combined dual task effect was very similar to cognitive, indicating that cognitive dual task effect is driving the correlation. We did want to acknowledge the limitations of this project. First, I want to emphasize that this is an exploratory study designed to identify general trends, and many of our findings benefit from additional research to confirm and clarify the relationships. We utilized a mixed clinical sample of multiple pathologies, and research has shown that different causes of dementia can have different patterns of brain volume loss as well as different patterns of activation during dual tasking. If we had sufficient power to analyze by diagnosis, we may have found different correlations. Finally, brain regions can have multiple and overlapping functions. We categorized them how we thought most appropriate based on the literature, but these findings should still be viewed with caution. So, to summarize our conclusions, we found complex and sometimes counterintuitive interactions between brain volumes and dual task performance in those with dementia. We have much to learn about how the underlying disease processes can affect function in this population. We also found specific motor relevant brain regions that appear to be related to dual tasking ability in this population. These may provide guidance toward which impairments to look for during assessment and to target with physical therapy treatment. Individuals with dementia also appear to prioritize motor function during dual tasking. Other research suggests that dual task prioritization may depend on characteristics of the component tasks, the environment, and the individual. This does indicate the potential for accommodative strategies that could be utilized during physical therapy. Finally, cognitive dual task effect appears to be more strongly associated with underlying brain changes and overall function than motor dual task effect, and should be utilized as a clinical and research outcome measure. This is a significant finding, as cognitive dual task effect is rarely measured in the clinic, and this recommendation would represent a change in current clinical practice.
This research was presented as a poster at the 2020 APTA Combined Section meeting in Denver, Colorado. My colleagues and I are excited to announce that this study was published in the Journal of Neural Transmission in April of 2020. You may notice in the bottom right-hand corner of your screen, there is a QR code. If you open your camera on your phone and take a picture, you will be able to access our article. We would like to take the time to acknowledge those who made our research possible. To our research advisors, Dr. Meryl Landers from UNLV and Dr. Jason Longhurst from Cleveland Clinic Lou Ruvo, thank you for your mentorship, expertise, and contribution to this research. Our publication and success would not have been possible without you both. Dr. Daniel Young, thank you so much for your continuous feedback. And thank you, Cleveland Clinic Lou Ruvo Center for Brain Health. Last but certainly not least, thank you all for your attention, and now we would like to take the time to answer any questions.